presentation for the new CPT codes and ICD10 codes coming out in 2021. We have a short runway, but we also feel that there's not significant changes in codes. The significant change this year is found in the E&M decision making and code selection, but they're not new CPT codes. It's just a different way of selecting your codes. We think it will benefit our providers. And so I have Nilima, our director of coding. She's also married to a urologist. So she's had conversations at home with her husband, as well as done a deep dive on our behalf to help us walk through the changes. The order that we'll go in is I'm going to first present the ICD-10 codes. Nilima will give us just a quick description. Then we'll look at the surgical codes, and then we'll spend most of our time on the E&M changes and what that means to you, your practice, your templates, and your code decision making. So I'm going to jump in, and first we're going to look at ICD-10 codes. And so Nilima, why don't you just give us a summary of these, and I will just click through.
Sure. So we've just gotten, I think they've just added some codes to make some categories of codes a little more specific than they were. Like, for example, the cerebrospinal fluid leak, we see they've added more description to it, whether it's a cranial leak, a spinal leak, whether it's spontaneous or if it's another kind of leak. So they've just added new codes to make the code a little more specific than it was. So it's not a lot of change. Same here in rheumatoid arthritis, we just have other specified sites coded, added more. This way we can avoid using unspecified at any point of time. I think similarly with arthropathies, arthritis of the TMJ, temporomandibular joint, in any age-related osteoporosis, other code, other specified or other site have been added, just so that we can use these instead of unspecified if we ever have to use. Again, juvenile osteochondrosis, unspecified leg, they've now separated it into right, left, bilateral. So there is laterality added on these. Similarly to the tibial osteochondrosis. So everywhere, I think the common thing is they've added more codes to make them a little more specific than they were.
Great. Okay. And so now we're going to jump into our surgery codes, and I just want all of our clients and our audience to know that we've tried to simplify this so that this may look too simple, but this year, I believe due to the pandemic, due to CMS's desire to change our E&M codes, I think we haven't seen a lot of change within the surgery codes. And again, I don't want you to think we're not keeping our eye on the ball. We've just tried to make this simple. We're only including these codes that are specific to our clientele. And so go ahead, Nilima, I'll let you jump into this.
Sure. So arthroscopic loose body removal from any of the joints, they've just added a little description on there. Josh, can we move to the previous slide? I think it said the size of the loose body has to be equal to or larger than the diameter of the cannula. In the past, we used to have a size specified on the foreign body which said more than 5 mm. Now it just said it has to be bigger than the cannula. That's the only description that's been added. But like Josh said, we code from your op reports, we look at your documentation. So as long as it says that it's a big, large body that had to be removed with extra effort, we can definitely code it separately. On the shoulder debridement codes, I think this is a welcome change because on the limited and extensive debridement, it was pretty subjective on I can think this is limited debridement. Josh could have thought this is extensive and vice versa. Now they've said on the 29822, if it's one or two structures, it's always considered limited, and 3 or more discrete structure debridement is considered extensive. So it's just become again super specific. There's some revised codes in the nervous system section. They've just revised little wordings there. Not a lot of change in our practical usage of these codes.
So what is the change, Neelam? It looks like they've just added an S onto.
That's all. It's anesthetic agents instead of an agent. Yeah.
Okay.
There is actually a new code in the gynecology section, the 57465. It says it's mapping of the cervix uteri during the colposcopy. This is a totally new code.
All right. And that's it. And
yeah.
So again, we wanted to make this seem as simple as what we've seen in the ICD-10 categories, these surgical categories. Now we're going to jump into some complexity that'll just require you really paying attention as we go through this. We think these changes will enhance all of our clients' coding opportunity, as far as we think in some cases where level 3s would have been billed in the past, we think with the right documentation, it can bump it up to a level 4. So that's really what we're shooting for, to go through this with you. Neelima's spent some extensive time looking through these. And the last thing, there's still some gray areas because this methodology is new. And so we want you all to know that we approach this as if we're an auditor. And we'll explain some of our approach as we go through it. But we want to make sure that until we have definitive documentation and understanding as far as some of the ways we look at this, we're going to err on the side of caution. We still think it's a great enhancement and ability to upcode where you weren't able to in the past, and we'll explain
that. So the codes that have changed in the evaluation and management section are the office and outpatient codes. So the consultation codes, inpatient, outpatient, hospital initial visit to subsequent visit codes have not changed. So they will still be coded per the 1995 or 97 guidelines. In the new patient section, 99201 has been deleted because it's very minimally utilized. The two major things that have changed, the two major decision makers for any E&M level will be time and MDM, which is decision making. We no longer require any elements in history or examination that are mandatory. Any relevant history or examination specific to that specialty is enough. And that's not even counted towards making a decision on the level of the code.
So Neelima, one of the suggestions I think that we are going to advise our clients based on their EHR is they kind of rule out, because I haven't seen many EHRs update their recommended use, right? They're probably still going through all the technological work to get that done. So we're just suggesting that our clients, when you get your pop-up screens or whatever your EHR is suggesting you use, you eliminate that from usage.
Right.
Don't go off of those suggestions until you get a confirmation from your software company that they have the new methods of selecting codes. So that's one suggestion we have. The other suggestion is potentially eliminating review of systems and your different histories from your templates.
Right.
Those are just check boxes and time you'll spend on something that actually doesn't add up to help you in code selection. And I say that with kind of the underlining, unless you're incorporating it into your medical decision-making portion of your documentation. But as far as the templates, the check boxes, that no longer makes a difference in code selection.
Yeah, and I think that this AMA has said these changes are because of the AMA's desire to reduce physician burnout, and I think the majority, a major portion of physician burnout is because of the documentation requirements. So an orthopedician doesn't really now need to document any review of systems or examination of the integumentary system or the nervous system or the gynecological examination. All of that doesn't have to be done. It's it's going to be very problem focused now. So that way, I think we get more time to make better decisions on patients. So now going straight into our table, AMA has published this medical decision making. So it's time or medical decision making. Josh, do you want to elaborate on whether we should be using time or this? There's a choice between using the two.
Yeah, and so thanks, Nilima. As we've talked about this and looked at most of our clientele, we do not think our clients are set up to, one, track the time. And I'm going to bring in something that I recently looked at. The COA has suggested here's a way to track time. And just as I looked this over, Nilima, I think we both agreed that we don't have any clients that are set up. This is like an attorney tracking time on a case that's off again, on again. But you'll have to do this for each patient, for each day, and we just think it's prohibitive in that sense. Yeah. So tracking all of these different functions of what would go into time. Now, we do want to highlight, this doesn't, the time that your MAs, RNs spend on a patient, that's not trackable, and we don't include it in the time. That's not part of the decision making. So it's only physician or qualified health professional. The other part of that is if you are going to use time as the mechanism for selecting your codes, there's two parts of it we want you to understand. One is you need to document it. If you've spent 45 minutes or 48 minutes, you need to document that you spent that amount of time. And secondly, on your documentation, you need to include what that time was spent on. You don't have to include the minutes, but include things such as a history exam, review CT, MRI, PCP communication, as well as the time spent documenting what you're documenting. But we also want to caution you with using time as far as audits go. And I'll close this screen. And if you are using time, your schedule, most of our clients see 20 to 60 patients a day. And so if you're billing a level 3, 4, or 5 throughout the day for 20 to 60 patients, you can't do that if they go audit your schedule, meaning you've spent more than 24 hours of time on patients. And so we just want to caution you that if you're using time as your selector, the audit may turn to your schedule, and they may audit your schedule and just tell you it's humanly impossible to bill this level of service for this many patients because there is not that much time in a day. So we want to focus you, our clients, on your medical decision making. And I'll let Nilima take over again from there.
So 992, so 201, like we said before, has now been deleted because of minimal usage. 99211, which is level 1 for established patient, nothing has changed about it. Very minimal documentation required in that one. So 99202 or 212, the level of MDM has to be straightforward. So under the so how we decide the MDM is there is 3 criteria. One is the number and complexity of problems addressed. The second one is the amount and complexity of data that needs to be reviewed and analyzed. And the third one is risk of complications and mortality or morbidity of patient management. As long as we meet 2 of these 3, we are good to go with that level. For example, for 99202, it says the number and complexity of problems is 1 self-limited or minor problem. Then there's minimal amount of data that needs to be reviewed. And there's minimal risk of mortality or morbidity or risk of complications. So even if 2 of these are minimal, we still meet that level. I think this level is not a good way to explain that. Let's go to 99203. It says you need a low medical decision making, low MDM. And under the number of problems, low is 2 or more self-limited or minor problems, 1 stable chronic illness, 1 acute uncomplicated illness. So if we have any one of these, and we see quite a few of these acute uncomplicated or 1 stable chronic illness in our specialties here. So we meet this low level of MDM here on this one criteria. On the second criteria, where the amount and complexity of data is concerned, we have to either meet category 1 or category 2. And in category 1, there's 3 bullet points. We have to meet 2 out of the 3. And the 3 are: there needs to be review of prior external notes from each unique source, review of results of any tests, ordering of any tests. And I think review of external notes has to be documented when you do anything of that sort. And the review of external notes that I could really think of is when the patient is being referred from outside, from either a PCP or any other a physician of another specialty, or a physician of a similar specialty from a different practice. You can easily dictate in one sentence saying, "I've reviewed notes from an external source," and just mention the source.
So Neelima, we are recommending that the gray area that we believe we're safe in is if it's from a different specialty within your same practice, or the same specialty from an external practice. Correct?
Yes.
Right.
And I think this will also apply when the patient first goes to the ER physician sees the patient, dictates something, and then they decide that you don't have to really go to ER at that point because it didn't warrant your presence at that time. But the patient comes back into your office. As long as you say, "I've read the notes from the ER physician," we will count that as a review of prior external notes from a unique source. Review of results, any x-rays reviewed, CTs, MRIs, anything reviewed counts under this bullet. And then the ordering of any tests. So as long as we meet 2 out of the 3, we satisfy category 1. And if we are unable to satisfy category 1, category 2 is assessment requiring an independent historian. Independent historian is when the patient is not able to give you a complete history, and you're having to get it from the patient's caregiver, family. But the one clause that AMA has added here is in pediatric visits, a parent is not considered an independent historian. So if you're having to take history from the parent, it doesn't satisfy this criteria. But if you're using interpreters, if you're using any other family caregiver, that very well meets that criteria.
And needs to be documented.
It needs to be documented, absolutely. Yes. Josh, can we just move back to we'll just finish off the risk here. Yeah, no problem. On 213, we just need a low risk of morbidity. And I think if you really do not talk a lot about side effects and risk of complications, we'll assume it's low. So, and this will be easily taken from the plan. Moving on to 204, we need to have, so under the number of diagnoses, we need to have 1 or more chronic illness with exacerbation, progression, or side effects of treatment. I was just thinking about it, like I think osteoarthritis, which progresses, is a chronic stable illness with progression. So this is very common. We see it very commonly. 2 or more stable chronic illnesses, or 1 undiagnosed new problem with uncertain prognosis. This is, again, well, for new patients, this is very common to see, because you're seeing the patient for the first time, you're going to have to do some tests before you actually diagnose what the condition is. So undiagnosed new problem with uncertain prognosis. So I think it will be easy to meet this for new patients. 1 acute illness with systemic symptoms, or 1 acute complicated injury. So acute complicated injury, any open fractures with arterial injury or anything like that, which is, anything complicated can be counted. So this category, I think, is reasonably simple. It's the amount and complexity of data, which is a little confusing. Amount and complexity of data here has 3 categories. And as long as we meet 1 of these, we are good to be moderate. But in category 1, we will have to meet 3 out of the 4 bullet points here. And the 4 bullet points are review of prior external notes from each unique source, review of results, ordering of any tests, and assessment requiring an independent historian. So in 99203, we had assessment requiring an independent historian as a separate category. Now it's gotten included in this, and we need to meet 3 out of the 4 here.
So Neelima, our conversation earlier, and my understanding of this is reviewing of results of each unique test. So if you see the patient for a elbow and a wrist, and you have unique elbow x-ray and a unique wrist x-ray, that
Mhm.
still only gets you
One.
one.
Mhm. 1 point.
And so if you order an MRI after looking at that, that
Mhm.
would then give you two.
2, right, right. So any number of tests reviewed will still count as 1. Any
But you
number of
still
tests,
need 3 in order
we
to
still
meet
need
this.
3 out of the 4. Yeah.
Okay.
So if we can't meet category 1, the other option is category 2, which is independent interpretation of tests. So when the patient is bringing films from outside and you're interpreting like a CT film from outside, and you're not reading the CT report by the radiologist, but you're actually reading the film yourself and interpreting the test, that can be counted as an independent interpretation of test. And the one catch here is these should not be separately reportable. So if we are reporting these using another CPT code, this will not be counted for an E&M criteria.
But we know from experience when we've tried to build the review of outside MRI,
Yeah.
even if the diagnosis changes and our client documents that, the
Mhm.
carriers are not paying
Paying
for that.
Yes, yes. The last category here is when you have to discuss management or any tests with other physicians. It doesn't talk about the specialty. So any multidisciplinary approach for any problems is good here. So 1 out of these 3 has to be met to be at the moderate level. And moderate risk of morbidity is again when there's prescription drug treatment documented, which is there in most scenarios. Any decision regarding minor surgery with identified patient or procedure risk factors. Any decision regarding elective major surgery without identified risk factors. So as long as decision for surgery is made, we meet moderate risk level, whether it's minor or major. And diagnosis or treatment significantly limited by social determinants of health. So if we meet, again, 2 out of 3 here. So even if we do not meet, say, the amount and complexity of data, as long as we meet the number of problems and the risk, we are good to go with level 4 here.
And so this is where we're viewing that a lot of level 3s, with shifting the documentation and shifting the focus of what our clients are documenting, will move a level 3 up to a level 4,
Level
whether
4.
it's new patient or established patient.
Right.
Okay.
Moving on to level 5, which is very rarely used. Under the number of diagnoses, it's 1 or more chronic illnesses with severe exacerbation, progression, or side effects of treatment. 1 acute or chronic illness that poses a threat to life or bodily function. I could really think of like a pelvic fracture that's profusely bleeding, which poses a threat to life. So that's I'm just trying to think of examples in our specialty here. In the amount and complexity of data, again, we have to be the extensive level. Again, we have 3 categories here. This is actually very similar to what we saw in 204. It's the exact same thing. We need any combination of 3 from 4 in category 1, and the 4 are review of external notes, review of results, ordering tests, and assessment requiring an independent historian, or just independent interpretation of tests, or discussion of management or test interpretation. So this is the exact same, but
so
the
it
difference is
would be a good summary for this just to say 2 out of 3 of the categories above.
Yes.
Okay.
So under moderate, we can just meet either category 1 or category 2 or category 3. Under extensive, we have to meet 1 and 2 or 1 and 3 or 2 and 3. So 2 out of 3. And there has to be a high risk of morbidity under risk criteria. Drug therapy requiring intensive monitoring, decision regarding elective major surgery with identified patient or procedure risk factors. So the difference here is we said elective major surgery that does not need to have any identified risk factors. Here it with identified patient or procedure. So it's basically a high risk surgery.
So Nilima, just a question for oncology clients. Is level 5 where they're going to be camping out if properly documented?
Yes, with their cancer surgeries, which are pretty high risk. Yes.
Okay.
Yeah, they will very easily meet the first number of diagnosis and the risk. Decision regarding emergency major surgery. So any emergency surgical decision will be counted under high risk. Again, I think it's saying major surgery, which is a little subjective here, but I mean, if you're making an emergency decision to debride a wound, it will not be in this category because it says major surgery. And per our guidelines in CPT books, any major surgery is surgery that has at least a 90-day global. So any zeros and tens will be ruled out.
Okay.
Decision regarding hospitalization and decision not to resuscitate or to de-escalate care because of poor prognosis. So this is super high risk. So like I said, I think for our gyne-oncologists, 205 is meetable wherever. Yeah.
Okay.
So this is time, like Josh has mentioned, that we are not set up to record this time, and it's just super tedious. And like the audits can focus on our schedules, but we still would like to give you all a split up of what time requirements are for each of these codes. 99202, it's between 15 and 29 minutes of total time spent. I think this is the difference. In the previous E&M codes, it used to say face-to-face time spent. Here, it's total time spent. And on the COA template, Josh showed you all of the activities that can be counted. For 203, it's between 30 and 44 minutes. For 204, it's 45 to 59 minutes, which is like an hour of your time for 204. So like if you're doing you're probably going to be able to see like 10 patients in a day max if we do 204s, all new patients, which is why, again, we want to steer away from using time. 205 is 60 to 74 minutes. What they've added is a new prolonged care service code, which is, again, I think here we have time requirements for the established patients. 211, no time required.
I'm sorry, I just jumped through that real quick.
Yeah. So 212 is 10 to 19 minutes. 213 is 20 to 29. 214 is 30 to 39. 215 is 40 to 54. On the next page, we have our prolonged care services. So if you see, the 99417 is the code that's been added to report any prolonged care services, but you have to finish a full 15 minutes after. It's not for portions of the 15 minutes time. It's a complete 15 minutes. So since 205 is 75 minutes, till you finish the full 15 minutes after that. So 74 plus 15 is 89. So from 89 minutes onwards till 103 minutes, you will get 1 unit of 99417.
Could they make it any more confusing on that? Is that a free 14 minutes if they go over the 74? I mean,
yes,
that's what it sounds like they're suggesting. Yes. Wow. Okay.
Yes.
Once again, a reason we're not recommending time.
Absolutely. Yeah. So, I mean, similar of 2 units of 417 is 104 to 118 minutes. So it's a full 15 minutes after. 3 times is 119 minutes or more.
Yeah. Okay.
Yeah, it's on the same lines for the established codes.
And so we've included the prolonged services here.
The prolonged care services, this is only for face-to-face time, Josh, and there's just minor revisions in these codes, and we don't use them at all. So these are not very relevant for us here.
Okay.
Again, this is again the same thing, that we don't use these codes as much.
So I'm going to ask a question on this. We chose not to include telemedicine. And and is it correct when I say this, that the telemedicine codes that were touted to be the new codes, I think we all thought it was addressing different actual telemedicine, kind of face-to-face E&M telemedicine. And I've seen, and I know you reviewed, is it correct to say that there's not really any face-to-face E&M telemedicine changes?
Yeah.
The new codes that I saw are like cardio, cardiology device monitoring and different
Yeah.
device monitorings, that it
Yeah.
seems like you need to have specific software and things like that. And it doesn't apply. I didn't see any that applied to oncology or orthopedics, pain management, anything like that.
Right. It does. It's not relevant to our specialties.
Okay. Then can you go through this E&M audit that you started to do and help me understand where we see the opportunity to go level 3 to 4 based on documentation? I know in this you found some areas that it was deficient, but I think if we explain that, just changing wording can help with some of that.
Sure.
So let's start right here. I'm sorry, I wasn't on the right page, but go ahead.
Yeah. So these were the diagnoses that were listed, and this meets it's one or more chronic illness with exacerbation of progression. So this meets the moderate level, which is the first level to meet the 99204 in the number of diagnoses.
Okay.
So we are good there. Going on to the amount of data and complexity of data that needs to be reviewed, we needed category 1 or 2 or 3, and in category 1 we needed 3 out of 4. In those 3 out of 4, we saw 2 of those here. X-rays were reviewed, so review of tests is satisfied. Ordering of tests is satisfied. We did not see that.
So ordering of tests, you and I had discussed this previous, but
Right.
here it says, I recommend MRIs. We would suggest different wording that I've ordered MRIs.
Yeah.
And that, at that point, getting ordered in there would meet 2 out of 4, correct?
2 out of 4, absolutely. So because there's no independent historian involved, and in the first section of this same chart, we did not find evidence of any external notes being read. It didn't meet the other 2 bullet points, and there was no independent interpretation of tests, and there was no discussion with any other specialty. So in the second criteria, which is the amount and complexity of data, this does not actually meet a moderate medical decision-making level. But the good thing is, like we said, we only need to meet 2 out of 3. So,
right, so because this didn't meet the second column, we only got, let's say, 2 out of 4. We're not done yet, right?
We're not done yet.
We still have one more opportunity to meet level 4.
Absolutely. And there we go. So we are actually meeting 204 here because of the risk that's mentioned, this prescription drug treatment. And that puts us at moderate risk. So because we have moderate number of diagnoses in that level, we have moderate. And in the risk level, we have moderate. And we met 2 out of 3. We're good to go with the 99204 here if this was a new patient.
And so I see here it says also a nerve conduction study was ordered.
Yeah.
And so that we would go back, but that doesn't replace if we used MRIs, right? It's just it meets the same category as ordering an MRI. Okay.
Ordering any number of tests, yeah.
So we're still at 2 of 4.
4, yes.
Okay. That helps me understand it. I hope it helps everyone that's watching this understand that. And so lastly, we just want to let you know we're here to answer questions. If there's any additional comments that lead to questions from us or that we can provide information, we're happy to help, happy to plug in. My guess is questions or comments will come back based on potential template changes. So again, we're here to answer those. Send us an email, coding@newportmed.com. Nilima is the first line of defense. Our entire coding team gets it. They'll meet, review it, and give you our recommendation. And primarily what we're looking to do is recommending documentation that will help you sit compliant at level 4. When in the past, based on the criteria, we might have only met a level 3. So we're really looking to help you there. and help navigate the E&M. We think the first quarter of this year, there may be a little bit of confusion or questions. So whether it's tomorrow or next week or next month, if you have questions as they come up, please send an email to us and we'll get you a response as promptly as possible.
Absolutely.
All right. Thank you very much. And we hope this has been informative. We hope we've simplified it, and have a great day.
Thank you.